You need to have a good reason to call for a shutdown of a nation.
There should be no social or family gatherings in homes or gardens. Only essential retail may remain open.
Health authorities have said they want people to be able to gather for Christmas.
About its effect on our mental health.
When it comes to the pandemic, the reasoning from NPHET is nearly always reliant on maths, the now famous or infamous models. When they're well refined, they can provide answers to nationally important, even life and death questions.
What number of people would be latently infected at a point in time? How many people are clinical? How many cases are we likely to see?
So how do they work? And what exactly will the modelers be looking at as we head into Christmas and swing into the new year? Remember the world in March. It seems no time and forever ago when we knew little about a new virus.
We have made the assessment that COVID-19 can be characterized as a pandemic.
Cities shut, borders closed, and hospital doctors rushed to figure out how to treat the new disease as public health and pandemic experts tried to understand how it spread.
The intensive care medicine community had to learn quickly, as did respiratory medicine, infectious disease medicine.
As all this was happening, in the background, epidemiologists and researchers worked to get answers to different questions to inform mathematical models instead of treatment plans.
Initially, there was no information available given that it was a completely new disease.
The modelers wanted to be able to predict how changes in the spread of the disease would impact the health system staffed by those same hospital doctors. Back then, like others, the modelers were trying to harden up what were vague answers to key questions. They wanted to understand
some basic parameters such as the incubation period, the latent period, which is the period from the person becoming infected until they become infectious.
How long is it from when a person first becomes infected through to when they first show clinical signs? That's really important in terms of the modelling.
On the pre-symptomatic period, the infectiousness during that period, which is quite important, and also the infectious period itself.
What percentage of people are likely to be asymptomatic of those that are infected? How long are people likely to be infectious once they're infected? All of these things were important to know.
By now, the world of science has solid answers to many of those questions. Assumptions and estimates were gathered from research across the world and refined through information from millions of tests and cases globally to help inform the models which try to predict the spread of the disease across the population.
The model is very sensitive to the assumptions that we make, and these assumptions are based on the best available data.
The population level modelling is then used to inform something else, the capacity modelling. That projects the potential impact heading for the hospital system at any given time. Capacity modelling is about two main things: time and space.
They get infected with COVID. It takes a while for them to become ill, to get tested, to turn up at hospital. So there's already a lag between the disease onset and turning up in hospital. Once they get to hospital, if they're going to get severe illness, there's probably a further lag. We assume, say, 3 days between going into a normal hospital bed and needing critical care, if you're going to need critical care.
If you have a lot of people on the road to hospital, you'll eventually run out of space on the wards. That's why a combination of population and capacity modelling is key if you're forecasting surges.
Perhaps the most important output of these models is the number of cases, particularly the number of symptomatic cases, because that was then used to help inform the healthcare demand and capacity modelling, trying to get an understanding of people who would be sick, would need to be hospitalised, and would need essentially to be in an ICU.
NPHET has been operating on the working assumption that for every 1,000 cases in people under 45 years old, there'll be 12 hospitalisations and a single ICU admission. But as the age profile of people infected increases, so do the projected numbers. In 45 to 64s, 50 hospitalisations, 10 in ICU and 3 deaths. 1,000 cases of people over 65, more again, 100 hospitalisations, 30 in ICU and 30 deaths. These are numbers NPHET say they're confident in, but they're not perfectly precise, as the modellers themselves tend to underline.
Models are just a representation of what might happen, and they're a simplification, inevitably.
There's quite a lot of different factors that will influence the quality of the parameter.
The model is only as good as the data that is used to create them.
Knowing how many people will need ICU is important, but to project capacity, they're also analysing for how long those beds will be needed. Somewhat counterintuitively, younger patients who do end up in ICU can have more of an impact on resources, as they're likely to survive but spend more time on the ward.
There's a severe disease. The patients are quite sick and don't get out of ICU for quite a while. Some patients even longer stay, up to 30 days. And we had one patient who thankfully has gone home, was in the ICU for 60 days.
All that means, by looking at the case data as it comes in, analysing the age profiles and examining the capacity in the system, the modellers believe they can confidently predict the likely impact of last week's cases on next week's hospital wards. For them, it's not just about the daily cases, it's about a whole lot more than what we get to see on the nightly news.